I'm thrilled to be talking to you two to talk all about LGBTQ family building, what it looks like. I think that this is a topic, I mean, fertility in general is something that is very mysterious to people. And then I think this on top of it probably seems even more mysterious. So I feel like let's start off by just introducing yourselves and talking a little bit about your initial journey with this.
I'm Dr. Owen. I work at CCRM Northern Virginia. I'm also gay. I have a wife. We have 2 boys. They are 7 and 5. And we conceived our boys using donor sperm IUI. And we obviously did this a little while ago. So we used Seattle Sperm Bank. We had a really good experience with them. And this was back when the sperm banks were not doing expanded carrier screening.
Okay.
And our clinic didn't really counsel very well on what it would mean if my wife did expanded carrier screening. And she just kind of signed up for it and got a result back that said she was a carrier for something rare.
Right.
And of course, I am a dork. So I not only did reproductive endocrinology and infertility, I also did medical genetics training.
Uh-huh.
So I'm like, okay, we have this result. We can't not use it. So I called every single sperm bank we could have used. And the only one that had done expanded carrier screening on any donors was Seattle. So that's why we ended up using Seattle.
And that's standard procedure now. Because I'm like,
Yes.
I mean, so it's since you're first, we're like 7 years apart in this process. So a lot has changed over that course of 7 years.
So that was 7 years ago. Yeah.
Well, for me, I haven't actually even heard that term before coming from my experience. So can you just give like a little definition of what that is?
Yeah.
Yeah. So that's the when we do the blood draw on the 2 partners, or on the intended parent who's going to be using the donor gamete, so sperm or egg, and we're trying to make sure you don't stumble into a rare genetic disorder.
Yeah.
So like cystic fibrosis, thalassemia, sickle cell disease, for instance. These are all autosomal recessive disorders, and I'm taking you back to high school bio here, but it's big A little a meets big A little a.
Yeah.
And then you got the 1 in 4 chance of little a.
The way that I understood it too, layman's terms, is so before I was married to my wife, I was married to my ex-husband, my husband, and he's Jewish. And so a lot of our friends had to test for Tay-Sachs. That's the, yes. And so it was like that, my understanding of that, where it's, it's a concern of a super rare gene with another super rare gene causing,
That's right. And then there would be a 1 in 4 chance if they were both carriers, right?
Correct.
So
right, but a same-sex couple does that as well as like a heterosexual couple, correct? Like what is the difference?
So in a same-sex couple, you would be matching up with your donor gamete. So like
your sperm donor.
Right.
So my wife came back positive as a carrier for galactosemia. So now we're trying to find a donor who's not positive as a carrier for galactosemia. So we don't have a 1 in 4 risk of having a child with that.
Right.
And at the time, the sperm bank's view of this was if they found a donor who was a carrier for something, that would make the donor defective. That would make the donor undesirable.
Yeah.
They wanted to have perfect donors, clean donors.
Okay.
And they were only doing Jewish panels, and they were only doing like sort of the big things, the things that everyone had kind of heard of, like cystic fibrosis, for instance. So, Seattle had a list of about 16 patients at the time that they had screened with the expanded carrier screen, the same one my wife had, fortunately. And it severely limited our choices.
Right.
Which in a way was a blessing at the time because it meant that we didn't have to have like the world is your oyster problem where we had so many choices. And we were able to find a really good donor who fit all our other criteria, all the fun stuff. Eye color and height and all that, and what he majored in college.
Yeah.
But
no, that's so interesting to know. Like, I would want to know what Taylor's criteria would be too.
Yeah, we found a Renaissance man, someone who was first an engineer and then later became an artist.
Amazing.
Yes.
So I'm Taylor Strecker. I am not a doctor. My dad's a doctor, which makes me think so. I think I'm a doctor, but she's a doctor and I'm not a doctor. I am also gay. I am a podcaster. I work with Whitney with Dear Media. And my wife and I, we decided we wanted to go the IUI route like you guys did. But because my wife, Taylor, also named Taylor, and Taylor, very, very gay of us. But she had some sort of hormonal issue that they were concerned about. So rather than IUI, we actually are now we went through IVF. We actually have embryos. We have 2, but we have not yet done implantation. So my wife is not pregnant, and we are going to probably start. We were going to start this fall, but we decided to push it off until very early 2024 for a bunch of reasons. But so that's where we are in the process. And when it came, so we are also using CCRM. They're incredible and amazing. And we used California Cryobank actually for our sperm donor. They were also fantastic. The genetic testing, like you were talking about, it's just standard procedure now. So you go through it no matter what. So my wife went through it. I have yet to do to retrieve my eggs, but I'm planning on also retrieving my eggs so we can both have one of our own biological children.
Right.
Although I'm not quite sure how I feel about it, but I want to talk more with you because I feel like maybe your experience can shed some light on where we are in the process. I'm also a crazy person, but the good thing about me is like I know that I'm crazy, so at least I can like work with my therapist ahead of time to prevent me like really losing my shit.
Like you're very socially aware of your craziness. Yeah.
Very, very, very. But so when it came to picking our sperm donor, we are very superficial and we wanted the hottest mofo on the face of the planet.
Why not?
And when he popped up, we were like, it's him. It was like undeniable. So it was like 3 days before Christmas. So we called and we were like, that's our guy. But so many of the vials had already gone. So it was kind of like, it's a race. It's a race to get his sperm because what is it? They only allow, 19 vials to be donated?
I don't know about that.
Well,
only so many families can have vials and then they cut it off.
Yeah, there's like some sort of law that's been passed where a donor can only donate X amount of vials. I don't really know much more beyond that, but basically there's a limited amount and if you don't get it, you're shit out of luck, essentially.
Right.
So
right. If you found the person that you wanted, then you have to move on to the next. Okay. So these questions may seem ignorant or stupid, but I'm just going to ask them because if I'm thinking them, then maybe someone else is thinking them out there.
Yeah.
For both of you, did you each know whose eggs? Like I know, Taylor, you just said that your wife went through the egg retrieval to then carry the baby that was then genetically her match. But was that like a known, like, did you always know that that's what you guys wanted to do? And same with you, Dr. Owen, do you have one of each? And then same goes for who's going to carry. Like, how did those conversations happen?
So my wife, my wife was like a born mother. Like she's wanted to be a mother since I met her, since forever. Like she even said that if she never found a partner, she would still have gone through this procedure by herself. So being a mom is a non-negotiable with Tay. So with that being said, it was kind of like, and she's also younger than me, which, I'm unfortunately biologically time is against women. So it just was kind of like a natural decision that she would be the one that was going to carry. She also really wants to carry. And when we went into CCRM, Dr. Notman, our doctor, she said, what happens is sometimes same-sex couples will come in and the woman who wants the child and wants to carry for whatever reason can't. And so it's like the partner who maybe doesn't want to carry is the one that ends up having to. And so she was like, okay, let's see what happens. But when we went into our uteri, it's plural, Tay, she kept saying this to Tay, oh my God, it's gorgeous. It's so beautiful and beautiful. This is like the story of our relationship. Like this is what everybody said about our dichotomy. And then I went in, it was like the upside down. It was like dark and like particles floating and like haunted. And she was like, good thing you don't want to carry. And I was like, shit, no, I do want to carry. But no, I don't. But so Tay's going to actually not only carry for her biological child, but if we decide to go the route of having my own, she'll also carry for me, which is kind of awesome, I think.
Yeah, no, totally.
But it works for us for sure. Yeah. But what was your journey like?
We have one of each. Sue went first because I was trained as an OBGYN and I saw every bad thing that can happen during pregnancy and delivery.
Right.
And there's a curse on OBGYNs who are pregnant that something bad will happen. And I was so afraid that something awful would happen to me that she'd be too afraid to go. Yep. So I was like, okay, you go first. So she went first and had the most uneventful, beautiful pregnancy and had our first son. And even her delivery was like the kind of delivery where me and the nurse looked at each other and she's like, she's lying to me. She's done this before. And then, and for me, I have always been very kind of androgynous, and it was actually like I had a lot of struggles about the idea of being pregnant because it's kind of the most outwardly feminine thing you can do.
Definitely.
And I ultimately decided that I wanted to. And every day I woke up and told myself, this is a temporary condition and it will be over, you know? And I'm glad I did it because, you know, I have my little mini me.
I think like starting from the beginning, and especially with you, Dr. Owen, saying you were doing IUI and then now, Taylor, you're doing IVF. I know that we wanted to talk about the differences, but I feel like same-sex and transgender couples obviously face unique fertility circumstances, but they don't know that they have so many different options. So before we get into the differences between IUI and IVF or same-sex marriages, why don't we just talk about like all of the options that are available to same-sex couples?
I start every consult with my, LGBTQ patients by saying, what's your dream? You know, what do you want? We need eggs, we need sperm, we need a hospitable uterus.
Right.
And I let them kind of tell me what they've sort of imagined things, how things will go. And then I do my best to basically make their dream come true.
Right.
No guarantees.
Right.
Like we've said. And the for the same-sex female couples, it could be IUIs, so medical turkey baster, so using donor sperm. And of course, there's options there, right? It could be a known donor.
Right. We thought about that. My best friend since I was in kindergarten. We were in love in kindergarten, and now we are both gay. So that really worked out. But I adore him. He's a Harvard professor. He's gorgeous. He's fun. I was like, this is a great sperm donor. He's also a shit starter, though. So I was like, a little bit nervous about that.
A little bit too much sass.
But Tay was really, she's like very territorial. And with this idea of having children. So she was like, I don't want to introduce any scenario in which it could get complicated and messy and have somebody that like actually wants to come in and also parent. So that's why we decided to go with the sperm donor. But I was very tempted to kind of like, it takes a village kind of like a mentality, you know? But
Dr. Owen, do you ever recommend something to someone? Because I feel the same. I had a family member who needed eggs, and I was like, I'm so there. Like, I would love to give them to her. And then I thought, but then that it just creates obviously such an interesting, complicated dynamic. So yeah, do you have an opinion on that, or is it very much just like whatever the patient obviously says goes?
Well, that's why we recommend third-party reproduction counseling, so that all the interested parties can sit down together and work it out.
Wow, we didn't do that. Ugh.
Well, if it was a known donor.
Got you. I was even saying advocating for myself wanting a known donor.
No, you could have.
Well, let's ship has sailed.
Yes, but but yes, that is that's a something that we require.
Wow,
if you're going that route, just so that everyone can work through any hangups they have.
That's incredible.
Right. All the possible scenarios that they may not even be thinking about could happen.
Exactly. And one of the most important that I always stress to patients when they're using donor gametes is, and again, eggs and sperm is what gametes refer to, is how do you describe origins to your child?
Yeah. I mean, and we're still thinking about this too, even with, a sperm donor. I'm kind of embarrassed to admit this because we probably should have known before we picked the person, which even further solidifies how superficial we are. But I actually don't fully know if he's somebody who is open to even meeting the child once they turn 18, or if he actually is closed. I don't know. We really should have looked more into that. Oops, where we are, it is what it is.
Yeah.
But this is something that I think about a lot, and I struggle with, like, because there's going to be a third person here, and they're going to have an interest in knowing their biological history. And so I'm not really sure how we're going to handle that.
Yeah, and that's something that I do talk about in all my consults. I talk to them about how anonymity hardly exists in 2023, and it's probably not going to exist in 18 years.
Right. Well, I think that's like maybe a good thing in the long run. I think leaving it up to the child, ultimately, what they're wanting to do and what they're comfortable doing. I mean, that's the route that we plan to go.
When do you start to think about, Dr. Owen, like when you start to have these conversations? Have you started to have these conversations with your kids?
The teaching is basically that you start to have these conversations basically as soon as they have consciousness. So like 3 years old.
Wow.
So there's a book that I recommend that's called What Makes a Baby. And I always have to pause to think about how to say that, because I once Googled how to make a baby in front of a couple in my office, and it's a very inappropriate Google search.
I can imagine.
Yes.
Yeah.
But it's called What Makes a Baby, and it's a very cute book. It's got very asexual drawings, and it's got like little figures that have eggs and little figures that have sperm, and it's got a picture of like egg and sperm doing a little dance. That's fertilization, and it has a picture of like the eggs and all their stories inside, and the sperm and all their stories inside, and how they're not two things anymore, they're one thing, and how they share their story. And then at the end, it talks about like who was excited for you to come into this world. And
Got you.
it's so cute. And and we read that story to our kids, and it helps me tell my kids about what I do for a job, which is fun.
Right.
But yeah, they know that they have a mama, a mommy, and a sperm donor.
And what was their reaction initially when, like, the first time you discussed it? Just very normal.
Yeah. You just totally normalize it. It's nothing.
That's what it is.
Yeah,
it really is just normalizing it. I mean,
Yeah.
I'm having a similar conversation, but different in that we're using a surrogate for our second child.
Mm-hmm.
And I had multiple miscarriages, and then the surrogate had a miscarriage. But I found that just telling Sunny the facts of what's happening in the most simplest terms is the best and easiest. Like, I remember when we had a goldfish and the goldfish died, and we asked a child development specialist like how to talk to Sunny about what death was, and she was like, you literally just tell him that their body stopped working. And like exactly what happened. And so basically we told him that mommy and daddy made this this little baby, and we're just putting it in another body that's essentially like the oven that's cooking it.
Yeah.
So, and he seems to understand it. And I think that normalizes the whole conversation. And if we were to hide it or not tell him what was going on, it's like I'm just then continuing the cycle of like stigmatizing all these different ways to get pregnant, which don't need to be stigmatized.
Yeah, no, exactly. And I would totally recommend you get the book that I'm talking about to read
will.
it to Sunny. Yeah.
Yeah.
But yeah, it is what it is. And I always tell people in every consult, I say, there's always a way for me to help you build your family. It's not if we can do it, it's just how we do it.
Right.
Right.
So.
Okay. So you did IUI for both of yours?
Yeah. So my wife did 4 IUIs with our donor. And then I just replenished the same donor for me for like 2 years later. And then I also required 4 IUIs, and then we had our second.
Wow.
But
so you had to go through 4 different.
Yeah. The thing that I always tell patients though about IUI cycles is that it is a marathon.
Mm-hmm.
You have to understand that you are embarking on a marathon.
Yeah.
The other analogy I use is USPS ground service. And IVF is Amazon Prime. Or in the other analogy, it's the sprint.
Right.
So they are both emotional in their own unique way.
Right.
But you have to prepare yourself for that kind of journey. You can't view IUI as like the easy way.
Right.
Or something like that. You just have to figure out what your priorities are. And, some people prioritize a more natural way, or maybe a less expensive way. However, I would counter now that sperm is so expensive now.
Yeah,
it's more than $1,000 a vial in most cases. Which is not what it was when we paid for it 7 years ago.
Yeah.
But it's about $1,000 a vial, or more.
It's a bodega bag,
Yeah.
And each
This shit is
IUI
expensive.
That's how I look at all the money we've been spending on our future child. I'm like, that's a Chanel. The implantation is a Chanel. I'm like, ah! So
it's hard not to think about the finances. When I think about it, I'm like, what else would I rather invest in? Like, there's literally nothing else. Yes, of course you can, think about the things that you would want to buy, but then think about, like, I guess for me, it's like I already have a kid, so I understand the love that I'm going to have for this child. Right. But you're not quite there yet. You know what the love for a Bottega bag feels like right now.
I really, I always say to Tay, if let's say my friends who is in a heterosexual relationship was talking about her husband and doing my actions, I would be like, he's the worst, leave him. I'm honestly like, I can't believe Tay's still with me. I'm really like the archetype of like a straight, white, middle-aged man. I'm the worst. Yeah. So, but also
I felt like that too.
Like instincts of a woman in shopping and girl math. I'm a disaster. So I'm really trying to work through my demons in therapy. We just had a therapy session about this the other day, and I cried a lot, but it was productive. I'm like getting through it, but we're getting through it as we're in it. Do you know what I mean?
Yes.
So
yes. It is so helpful. It's so helpful to be having those conversations while you're in it, because you're inundated with so much information that you don't even realize you're going to have to process. So it is really, really helpful for you as a couple to be talking to someone about all these different confusing feelings that you're having, you know?
And also, I think that's why I'm so happy that we were initially upset when it wasn't IUI because that was the plan. And like you said, it's less expensive.
Right.
But the kind of, and you can correct me because I know I'm going to be wrong, but it feels like we are a little bit more in control with the timeline.
Totally.
Yes. With IVF.
Totally.
And so I'm really happy that we ended up having to go IVF. Even though it was more expensive, I would rather pay a little bit more to have a little bit more control over when, especially because I'm so hesitant about when it's an ideal time for us to do it. I know my mother-in-law is always like, there's never an ideal time. And I'm like, shh, but I know she's 1,000% right, but at least there's a little bit more control, because I feel like had we done IUI and Tay got pregnant immediately, I would have freaked out. Mm-hmm. So at least now we're kind of agreeing on when the best time for implantation is. But I think something that I'm a little bit skirting over and overlooking is I think in my mind, I'm just saying and when we're ready, it'll happen. And it's implantation's not a guarantee.
Mm-hmm. That's also true.
2 embryos, which is ideal, but also I know people that went through 5 embryos, 8 embryos and nothing. And so statistically.
Yeah, the difference is so with a same-sex female couple undergoing IUIs, you're trying to approximate the heterosexual couple sort of having natural fertility, norm. So that's going to be somewhere around maybe 25% each month, which is not great. And an embryo transfer, if you have the highest quality embryo, that could be 70% chance in that month. So that's a majorly different percentage. But I don't know what the percent chance are with your embryos. I don't know if you know that.
They said it was in the 60s.
Okay, that's great.
Okay, great.
That's a high quality embryo. So,
okay, good.
But that's still maybe 3 times as better than the IUI.
Right.
But I distinctly remember my wife having her first IUI. And of course, you go into it, and I always tell patients, okay, you got to go into this thinking, okay, it's going to take 4 to 6 tries.
Right.
It's going to take 4 to 6 tries. But then my wife had her first IUI, and I went, it might work. It might.
Yeah. Exactly. Yeah, exactly.
So once you do the IUI, can you then, how long do you have to wait until you start again if it doesn't work?
Oh, you just the next month.
And same with IVF?
It's just the next month. Okay.
Yeah, great.
I mean, unless there's a miscarriage and then we're having to follow you down and
Right.
That's what happened with our surrogate. She miscarried at 8 weeks, and then there was the process of getting off certain medications and then going back on. So then that was another added 3 months, So each time you try, you don't realize, like you said, it could happen the first time and it could not happen for years, So the goal is, I think, to just release control, which is the hardest thing to do because it's just not on our timeline at all.
I know. My biggest fear is that, ironically, My biggest fear is that neither embryo takes, and then we're on this journey that you hear a lot about with a lot of couples, whether they're same-sex or heterosexual. And then we're like going back into the egg retrieval, and then it's like, well, now do I go in? And it's like,
I know. I'm in the same exact mode as you, and every time I go there, I try to tell myself, we're not there yet. Stop going to that place. We'll cross that bridge when we get there, because what can we can't, we have no idea, right, Dr. Owen? Like, what would you say to us?
Yeah, like about 70% of my job is psychological counseling. And what I tell you is take one step at a time. Understand that you're making the best decisions you can with the information you have available. Your doctor is doing the very best they can to help you make the best decisions that you can, and that you have to like take each step having no regrets and being in step with your partner.
Right.
Because no told you so's are allowed in my clinic.
I'm bad about that.
Yeah, you can't do it like that. You got to be together.
Right.
And then you just have to know that you did the very best that you could. And then you just take the next step. And like I said, there is always a way. You just have to keep knowing that there is always a way. It is not if, it is just how.
I know we were going to do a ton of financial questions, but this is something that really is like plaguing me. And I've talked about it with my wife, and it's like, we are committing to doing this, but I feel like we need to commit to also like a financial amount that the highest will go. Yeah. Do you like, have you had couples where they like hit their peak and then they've they've maxed out of what they can afford, and like, what are some other course of actions if that happens? Like, I don't even like, is that a normal thing to discuss, I guess is the question? Or is it kind of just like, once you're in this, you're in it, and you just gotta like figure out a way to make it work, financially speaking?
So I always encourage patients when they're making their decisions to consider their emotional bucket.
Okay.
Consider their financial bucket. When they're making their decisions with me about which path they're going to take and how they navigate, how to keep those buckets as full as they can.
Right.
And certainly there can come a time where the emotional bucket might, get too empty, or the financial bucket might get too empty. And I do have patients who will actually take a break to switch jobs.
Wow.
To get benefits that will improve their ability to access care.
Wow.
Because there are
there are
like jobs out there who have like golden ticket to
they cover fertility.
When you're considering either open season, if there's a way for you to switch into a different benefits package through the job you're in, or if you had the opportunity to have a lateral or an upward move in your work, it's important to consider your fertility benefits, because there are absolutely lots of companies out there that are offering benefits that are just absolutely incredible for fertility.
Yeah.
Right. And we were saying, like, when it comes to, even if you're young and you just want to freeze your eggs, that still could be $10,000, or whether you're our age and trying to get pregnant. I think it's important to think about, when you're looking for a job, like the company's ethos as a whole and how they're going to support you. Totally. Have you, I'm sure there are people coming to freeze their eggs that are looking to undergo like any kind of gender affirmation treatment or anything. I feel someone told me recently that someone took their daughter in because they thought that this was maybe going to be the path that they were taking, but they wanted to have her eggs in case. And I wanted to know what your experience has been with that.
Yeah, so I actually partner with the Pride Clinic in DC at Children's National, and so I see. I guess I've probably done maybe, I don't know, 8 consults at this point with adolescents who are looking to transition. And so I support them and offer free consults to those kids and their parents. And honestly, it's mostly for the parents. To discuss fertility preservation. It's much more important for the individuals with testicles because once they start hormone blockers or like estrogen treatment, the testicle is a factory of sperm.
Okay.
And if you shut down that factory and then later on you wanted to turn the factory back on, it may never turn back on.
Wow.
Or if it did, it may only turn back on in such a way that you would make very, very few sperm, like need a surgical extraction, and like it just may not work.
Right.
So for those patients, it's much more important for them to try to get a specimen. But the difficulty is, where are they in their pubertal development?
Right.
And are they at a point where they have actually started to make enough sperm to get a sample? And sometimes self-stimulation is a trigger for them. That they don't like that part of their body.
Right.
And so it can be really challenging.
Is there an ideal age or like a general age where it's optimal to retrieve the sperm?
Usually around the age of like 14 or 15 is when they can masturbate and get a sample that would be adequate for freezing. And we usually work with Fairfax Cryo, which is local, and I'll send those folks an email. They're awesome, and I say, okay, I've got a transgender kid. They're going to come in. I want you to work with them, and we freeze it in such a way that no matter who their partner would be in the future, it would be suitable to use like with a surrogate or whoever, because that's important too, because there's FDA guidelines for that. But I make sure that they're like treated like red carpet rolled out, because this is so sensitive and difficult.
Of course.
And then for the individuals with ovaries, fortunately, there's really very little pressure on that side, because it's taking testosterone is analogous to being on a birth control pill, to the best of our knowledge at this point. So the studies on that side have basically shown that for individuals that pause testosterone later, if they go through IVF compared to their peers, they have similar outcomes. So they can even pause testosterone, and if they had a partner who had sperm, they could even have, intercourse in a natural way, and could even carry a pregnancy. So I usually am reassuring them and reassuring the parents that they don't need to freeze eggs. Yes, that would be the most conservative thing to do, because the knowledge is still evolving and all that, but it's probably analogous to taking a birth control pill long term, and the eggs are just hibernating. They're just, you're still cycling. Age is still the most important factor. That's still the party line.
Okay.
Given the fact, like, regardless of sexual orientation or identification, gender identification, I have a question just about in general, like, so many people now we're talking about freezing our eggs. Like, is there should we be doing it like way earlier than we're even considering? Like, should women be doing it in their 20s?
The age is the most important factor.
Right.
So, yeah. I guess fortunately, because of like what Whitney was saying, these companies like the Facebook and Googles of the world that are offering this to their employees, I am seeing more and more women in their 20s who are coming to see me to do it at an age where it'll be much more successful than when it was first kind of becoming a thing, when we saw most of the patients in their upper 30s, where it's just not going to be as successful.
And I think also, don't you find, and I kind of hope this is the case, but women are trying to get pregnant later than we used to? Or is that maybe just like an urban city thing? Because it feels to me like women are obviously working towards careers now, not really trying to get pregnant until early mid 30s, it feels like.
It's definitely regional. I'm from Georgia. I don't know if I've said anything too Southern, but I am from Georgia, and it's definitely regional. I've got friends from back home that had babies when we're supposed to.
Yeah, I literally, none of my friends, I feel like none of us got pregnant after before 30.
Yeah,
and everyone's almost still trying, and we're almost 40.
Yeah, same. Definitely, all my friends. I'm so far behind. I'm 40, so I'm really far behind my friends. But most of them were earliest early 30s, more mid to late. So yeah.
I just want to make sure that we have talked about all the possible scenarios for all the couples that come in, just so that we're covering everything. I know
Sure.
obviously CCRM doesn't have their own sperm bank or the where you, excuse my lack of terminology, but an egg.
We do have an egg bank. It's for CCRM patients only, but we do have an egg bank.
Got it. But not a sperm bank.
All right. So if we have 2 individuals with ovaries that come in, we could do donor sperm IUI. We could do IVF with donor sperm. You could be doing autologous IVF, meaning this person's egg, sperm with their egg in their body to carry, or reciprocal, where you give it to your partner
Like what
to
I
carry.
would end up doing. Yes.
Correct.
Okay.
All right. So we call that reciprocal IVF. And of course, it could go both ways. Like,
Right.
Taylor 1.
Very confusing. Taylor and Taylor. This is where it gets really confusing. Yeah.
Taylor 1 could create an embryo to put in Taylor 2. Taylor 2 could create an embryo to put in Taylor 1.
Yeah. We
Okay.
actually thought of maybe doing that just to both bond. And then she said she didn't want her egg in my body. Rude.
Oh,
Because I've lived hard. Let's just be real. I support her saying that.
that is hilarious.
Fun fact. You can induce lactation as the partner
No kidding.
and breastfeed your partner's baby. My wife did that for our second son.
That is amazing.
No
that I
way.
want to do because I
Yeah.
feel like that is such, breastfeeding, I've never done it before, but I can only imagine it's very bonding for the baby and the mother.
Yeah. It just creates resentment for the person who's trying to breastfeed and having trouble.
But the good thing about it is that you have 4 boobs to choose
Correct.
from.
Good.
No, it was
opposed
good
to
for the
only-
baby, just bad for the psyche of the mom who just delivered.
Yeah, that's
Interesting.
true.
I'll definitely want to do that.
And you can do that too if you use a surrogate, Whitney.
Oh, wow.
You could induce
Yes.
lactation to breastfeed your baby.
Yes, she said she would be willing to pump and send for as long as we wanted.
No, but you could induce lactation to breastfeed your baby.
Oh my God, there's no way I'm doing that.
She's like, the whole point is I'm keeping my body. All right.
I'm
no
not.
way.
No.
No,
But,
and
but
I
nice
breastfed
thought.
for way too
Yeah.
long. It was not I totally was guilted. I succumbed to mom guilt on that one.
Yeah, I get it. I get it. I feel like if Timmy had the option, if I could induce lactating in him, he would probably want to for sure. I get it.
That's amazing. I love it. Okay. So then on individuals with testicles. Okay. So they need an egg and a uterus. So for that journey, they need a donor egg. That can come from friend or family member. And this is the same for sperm, right? It could be friend or family member. That's the known option. It could be from the bank for the egg or the sperm, like we said. And then you could do agency donor for your egg. Okay, so that's where you work with an agency. They identify an individual who would come, get medically cleared by the clinic, go through an IVF cycle, have their eggs retrieved fresh. They would never be frozen.
Okay.
They would be inseminated with the partner's sperm. And what most same-sex male couples would do is they usually say they each want one biological child.
Yes.
So you divide the eggs into 2 cohorts. Each inseminates 1 cohort. They each have their own bio, set. And then you have 2 sets of embryos. And then you have your gestational carrier that they've picked also through an agency. Some agencies will do egg and gestational carrier.
Right.
Some agencies will only do one or the other. And then you pick which embryo is going in first. And then some gestational carriers will sign up for a sibling journey and say, okay, I'm going to do your first kid, and then I'll come back to you, after and do the next one.
It's amazing that there are so many options now.
Yeah. But like I said, it's always what's your dream? And then and like you had said, sometimes like Dr. Notman saying to you, sometimes the person who doesn't want to carry has to carry.
Yeah.
Sometimes we have that conversation where we'll go through the history and something will come up where I'll be like, okay, so let's just broaden our, let's broaden it a little bit and let's talk about how we might need to consider this. But yeah, as much as I can, I try to honor what they bring to me.
That makes total sense. Success rates. I feel like this is always something that doctors have a hard time answering. Timmy and I are always like, give me the numbers, give me the odds. Like I need some sort of, so is Is there a success rate at your CCRM? Do you have a success rate? Is that something, I know that we were talking about the fertility CCRM has to put out like a certain number so that people can know what their success rates are. So just explain to us that process.
So with IUI, because it's medical turkey baster and we're basically just like throwing some stuff against a wall and hoping something sticks.
Right.
That, like I said, is just trying to approximate sort of normal reproduction. And that's, I'd say the highest that may get is like 25 to 30%. And that may have something to do with the donor you select. And I should say this, that when you're looking for a donor, asterisk beside, if it says they have known fertility in some capacity, that's a good sign.
Okay.
Right? 'Cause
Okay.
then you know the sperm works.
Right.
Right.
So that's always a good sign. And then obviously at the time of the IUI, we get a total motile sperm count in the clinic. And we want that to be at least 10 million.
Okay.
And if it's less than that, there's a lower chance it's going to work.
Okay.
If it's more than 10, great. But 10 is really the number we're shooting for. And this is also kind of a funny story. On the IUI that resulted in our first kid, the midwife who did it, it was 5 million, and which is low.
Right.
And the midwife who did it looked at me and my wife and said, "Better luck next time." It was
Just right then and there.
It was the quietest drive home from the clinic.
Oh.
We were so sad.
Oh.
It was awful. And then
So that sperm though doesn't get tested beforehand?
there's a guarantee given to you by the sperm bank.
Okay.
And if the sperm bank doesn't meet the guarantee, like I was ready to write a little note to the sperm bank and say, "Hey, this one didn't meet the guarantee," and they'll give you a vial to replace the one.
Okay.
But of course, if it works,
Right.
you don't get another vial. So
Right.
we were delighted because it worked.
Right.
So it was obviously good sperm, but you don't need 10 million. All you need is one.
You just, right.
Yeah.
That's
But-
just that. Yeah.
but
I
it-
get it.
But I'm very careful when I do IUIs to, if it falls below 10, I tell patients like, "Listen,
Right.
let me tell you a story."
Yeah. It's all hope is not lost.
Correct.
Right.
Correct.
Totally.
But the goal is
Totally.
10. So IVF, that's just harder. At CCRM, I always tell patients I've hit the jackpot on jobs because we arguably have the best embryology lab and best pre-implantation genetics lab like in the world.
Mhm.
And the most important decision that a patient's going to make is their lab.
Mhm.
And if they're going to do pre-implantation genetics testing, that lab.
Mhm.
Okay? Because obviously taking a 5 to 7 cell biopsy on an embryo, that's risky business and you can
Yeah.
totally screw it up.
Yeah.
Okay. So basically, as long as you trust your pre-implantation genetics lab, I do recommend doing that test. Okay. So at CCRM, totally should do it. And then you have to look at the grade of your embryo.
Right.
And hopefully your lab is putting out high quality embryos. And at CCRM, obviously, we put out really high quality embryos. Since 2008, we've got data that tells us what's the percent chance of live birth by grading. That's how you know what your percent is, which is somewhere in the 60s.
Right.
I just know
Yeah.
that CCRM is very scientifically rigorous and
Mhm.
anal retentive when it comes to this
Mhm.
stuff, which is exactly what you want when people are dealing with your eggs, your sperm, your embryos.
Yeah.
Yeah.
When it comes to the success rates and how I talk to patients about success rates, I walk them through sort of what the averages look like in terms of starting with 10 eggs, eight mature, 6 fertilize, about half become a blast, and then what we'd expect for age and how many would be chromosomally normal, and then sort of on average, they're going to be between 50 and 70% chance of live birth if they come back normal based on grading.
Yeah.
So they're in that group.
Right.
And that's how I set their expectations about sort of how many cycles they might need to go through in order to be successful.
Uh-huh.
That's how I talk to them about success rates. I try to not give them numbers that are not tangible and that they can't, because it doesn't help.
It doesn't help. It doesn't help. It's like such a gamble. It's like what we think we want numbers, but they don't really solve the problem.
Yeah. I try to tell them more about setting expectations. Like, okay, you had
Yes.
you had 10 or 12 antral follicles and your AMH tells me you're not going to have a stubborn ovary, and I think we'll probably get about 10 eggs retrieved. So these are the averages. So based on your age, I think we're going to get 1 chromosomally normal embryo per cycle.
Mm-hmm.
And if you want to bank embryos and you're trying to have 1 kid, we're going to have to do this twice. That's
Right.
what I think. So
Right.
that's how I talk to patients, because
That I
that's
think
kind of
is
what
really
they want to
refreshing.
know. Yeah.
Yes, I think that's refreshing, and that's what we deserve to hear. Nobody wants to be lied to, even if the truth is going to sting. You know, like we just want the truth.
Yeah.
And it also helps to, like, you know, prepare yourself for
Exactly.
whatever the journey is going to be. So with that being said, I know
Exactly.
that you're not my direct doctor, but knowing that we have 2 embryos and that they are at 60%, what would you predict would be
That you'll probably have 1 live birth.
1 live birth out of 2?
Yeah.
Wow.
And it'll be awesome if you have 2.
Right. I like 1, so I'm okay.
Yeah, but that's what I tell patients, right? That
Right.
that each embryo has about a 50 to 70% chance of live birth.
Right.
And if you're trying to, for each live birth desired, you need about 2, right? Because it's about a coin flip.
I know. So that's why I feel like we just implanted our surrogate 2 days ago. I have 5 embryos, 2 girls, 2 boys, 1 unknown. Wow. The boys are technically a little bit stronger than the girls. They matured a day earlier or whatever, but we already have a boy. So we put in the strongest girl. It didn't work. We put in the second girl, even though knowing that the boys were stronger, it was still only like doctors were like a 5 to 10% chance difference or something. So it's still like, I feel like each time we're doing it, the odds are getting better, but still have no idea. Could go through all 5 with nothing. And I know I say that very cavalierly, and I don't, that's not how I feel. But that's kind of, after so many years of going through this, like kind of the energy I have about it at this point.
Fingers crossed.
Yes. Thank you guys.
And I'm going to sprinkle you with my pixie dust. I have pixie dust.
Please do. And the due date would be on what would be my late dad's birthday. So I feel like there's some sort of good omen there, but I also don't want to like read into anything, you know? Anyways, you guys, thank you so much for taking the time to do this. I've learned so much. I'm sure, Taylor, you have,
Yes.
and everybody listening. I appreciate this. Thank you guys so much for doing this with me.
Thank you so much, Whitney.
Thank you.
Of course.
Good
Bye.
luck with everything.